So the amount left hand is very important for hernia surgery. Not the scissor which is cutting is important. The left hand which is giving good traction is very important.
Yeah, the laparoscopic surgery is traction and counter traction.
Yes, sir.
Basically,
Yes,
all
sir.
procedures counter traction, traction.
Traction, counter traction. Slightly
What about a
smaller.
Dulux fascia? That also you cut?
This lateral fascia will cut so that the mesh will lie flat.
Yes.
At the end, Dr. Sendhil, you show the myopectoral orifice critical view
Yes, sir.
also.
Yes, sir. Yes, definitely.
Because I think for the audience it is very, very important.
Sure.
Those who are probably the juniors and who don't know,
Yes, sir.
we
Definitely.
must explain them the myopectoral orifice critical view.
Definitely.
The 9 points.
Yes, sir.
What is that?
This is the sac, which there is a small rent in the sac.
That's what I was thinking. How did that rent occur? Very good dissection, Sendhil. Bloodless.
Thank you.
Absolutely. I appreciate your technique and I really I'm enjoying your surgery.
Yeah, this is absolutely a treat.
Thank you, sir. Thank you.
This is my third visit to your center.
Yes,
Earlier 2 times I've come and I was really.
Yes, thank you very much. Because of the faculties like you, only the conference success. Everything depends upon the faculty, the presence of good faculties. We want to give maximum knowledge to the delegates who are attending. But in that process, I think there were a little bit of confusion. So forgive us if there is any.
It's a wonderful scientific, wonderfully crafted scientific program.
Yes, sir.
Again, the compliments for that as well. And I am sure that there are a lot of learning points for everyone who is attending this conference here.
I think Sendhil likes to drive on the highway
Sir.
rather than in narrow lanes.
I think you will be slowly putting in 30 by 30 mesh, I suppose. Here.
So I'll show the anatomy now, sir. So this is myopectoral orifice. You can see this is the conjoined muscle. This is superior pubic ramus, lateral border of rectus, and psoas muscle. This is the boundary of myopectoral orifice of Bruce chart. So psoas muscle are here, lateral border of rectus, conjoined muscle, superior pubic ramus. So the mesh should cover all these potential defects. That if you cover all these areas, you are covering the femoral, direct and indirect defects. So you can appreciate the indirect sac. So the sac is lying here. It is in the canal, and there is no bleeding.
It's very important.
Yes, sir.
I want to tell the audience here sitting that the distal part of the sac has to be cauterized well.
Yes, sir.
Because if you don't cauterize and if it retracts, later on in the post-operative period, you will have a big hematoma in the scrotum.
Correct.
So
Yes,
the
sir.
cauterization of the distal end of the sac is very, very essential.
Essential.
I usually do it with a bipolar.
Yes,
so
sir.
that it is permanent and does not bleed again.
Again,
So
yes, sir.
I usually use a bipolar to cauterize the distal sac, which is very, very important. Otherwise, the patient will always have a big hematoma and will wonder what we have done.
So the anatomy for the postgraduate, this is the right, I am operating on the left side hernia. So this is right rectus muscle, midline, left rectus muscle. This is midline, pubic symphysis, and this is superior pubic ramus on the left side, and this right side are not exposed.
Beautifully, the
wonderful.
Bogros space and the Redje space.
Redje space, yes, sir.
So
This is
Redje space and Bogros space.
This is a Redje space, that is a retropubic space, and you have got the lateral inguinal space, that is where we have got all the nerves below the iliopubic tract. So we have kept all the fascia intact. The nerve is not visible here, and this iliopubic tract is hidden by this fat, and this is a conjoined muscle, inferior epigastric vessel, and I'll do some cut here.
The critical view of myopectoneal
Yes, sir.
brings out 9 points.
Yes, sir.
Which I can enumerate one by one.
Yes, sir.
If you want, or
Yes, sir. Definitely, sir.
or you enumerate.
No, sir. You can enumerate.
See, the first thing is about 2.5 centimeters below the pubic symphysis. You dissect that area. That is one. Then you go up and you see the direct hernia. Then you go down and you look for the lipoma of the cord. And then you come up again and then dissect the indirect sac. Then you come down again and do the this thing, palatalization of the cord structures, and then you point to the anterior subic spine, and that is those 7 points which you demonstrate. What is known as
So what Piyush is pressing is press the anterior superior spine. So that is the anterior superior spine.
So these are the 7 points you demonstrate.
Yes,
that
sir.
is known as a critical view of myopectoral orifice.
Yes.
So that you covered everything, your dissection is adequate.
Yes, sir.
And then you put a mesh which is wrinkle free.
Yes,
that
sir.
is the 9th point.
Yes, sir. So this is the sac which I left. I am putting a loop to it.
The PDS loop, is it?
This is a polypropylene loop, but we are going to use the same suture for fixation of the, proline polypropylene. The same suture material we will use it for the fixation of the mesh.
20 proline.
10 proline, sir.
Okay.
The same, we will use the other end for fixation of the...
Yeah, what about the medial part of the, the dissection down there of the peritoneum which you have done?
Yes, sir.
The medially turned vas turns medially there with a sling. That do you see that, or it is just the...
Actually, the limit is medially, if you carefully see, you will have the round ligament crossing the, medial umbilical ligament crossing this area, vas difference. That area is one of the landmark that is a lower limit, and you can see here this is obturator foramen. If you open this face, you will have the obturator nerve also.
Sendhil, the point what talks about is
yes, sir.
that about 3.5 centimeters from the internal ring.
Yes, sir. Yes, sir.
And second thing, when you lift the peritoneum, those structures should not get lifted. So if you lift the peritoneum this side, the cord structures should not be lifted. So it means you have done enough palatalization of the. That is what it is.
Yes, sir. Okay. Sister is preparing the mesh. What I will do, I will put the mesh inside, spread it and fix it with the same 10 polypropylene suture.
Important point is change of glove.
How do you prepare? Anything particular about the preparing the mesh?
Important point is
can you show the mesh? Change the glove. Yeah, that is very important. So sister is preparing the mesh. This is a 15 by 15 polypropylene mesh, macroporous mesh, and she has curved it on either side. This will go on the lateral side, and she has made a cut here. This cut will be lower medial, that is towards the prostate. So this side is straight, this side is she has cut for prostatic area, and laterally she has curved it on either side. So that is how she used to prepare. So she prepares by herself. She uses that glove cover, she keeps or mesh cover, she keeps the mesh over that cover, and she actually folds it. First she will fold into 50%, then she will fold again 2 times she will fold it, and then she will give the lateral aspect of the mesh. I will hold it, I am not touching the mesh at all, I am just holding with the instrument, and the washer already has been removed, and I am taking it to the lateral side. This is a soft, I use a soft polypropylene mesh. And other thing, actually, the infection was not a problem in our case series, but once we had, actually we never had any infection, we are doing it for so many years, but once we had 2 or 3 infection within a short span of time, that happened about 2 years before. Then we are very much worried about this because it was new to us, and we are very much worried. Because to treat a mesh infection is very difficult, and patient also will have a lot of problem.
Now,
so then we were assessing what could be the reason. Then finally we came to know that during that time we had demo machines, 2 demo machines of 4K laparoscopic system, demo system. So two machines came at the same time, and we kept it for nearly for a month. Both systems were there in the hospital for a month, demo system. I could understand that during that time only all the infections happened. So then nowadays any demo instruments, if they want to bring it to the OT, they have to give it to us at least 2 days before. They will keep it outside, fumigate nicely, then only they will take it inside.
I think it's a good policy.
Yes, sir. And because those instruments were going to all the places before coming to us.
Yeah.
So that should be, we should not just like that take it inside.
Now, Sendhil, the only problem with this macroporous meshes is that you cannot use tacker, because the tacker will go through the pores and may not had a good purchase.
Yes, sir.
You'll
Yes,
have to do only suturing.
Suturing.
In case,
Yes, sir. Yes,
because
sir.
tackers will not be right thing here probably.
Yes, definitely, sir.
How much should be this mesh? Generally, would you place it medial side?
Medial side, I'll be crossing the midline. Sometimes, if I am dealing with a large direct hernia, I will take more mesh on the medial side. And if it is a bilateral hernia, I will have a larger overlap with the mesh on the medial side. I will prefer to use a little bit heavy mesh with more overlap on the medial side.
Yeah, in a larger hernia, I think you should use microporous or medium.
Microporous,
medium weight,
yes,
or
sir.
medium weight.
Medium weight means
Yes.
microporous, medium weight with more stitches. I place more stitches on the medial side so that.
And in a direct hernia, I think if you can suture the sac onto the abdominal
yes, sir,
muscle,
yes. Yeah.
it will reduce the seroma formation,
And that will give
it will prevent
support.
the mesh from going into the sac as well.
Do you fix those pseudo sac always? What do you do?
No, I don't fix the pseudo sac.
Then you take any incisions on that. How do you prevent the seroma formation by external pressure? What do you do?
I will place a compression dressing for which will be removed by the patient in 48 hours. That is the only thing which we do. And normally, what I feel, if you are in a plane, I mean that's my personal this one. If you are in a plane, if you are going there, you are identifying a plane which is the best plane for that hernia repair. So if you stay in the same plane until the end of the procedure, you are not damaging any lymphatics or anything. So the chances of seroma. So actually, we have not done any intervention for seroma purpose. Seroma, only one patient we actually did evacuation of hematoma. I mean, actually it was like a hematocele. So which we did evacuate, we were waiting for months together, but it didn't get resolved. So that we did, that is the only experience. But seroma, we have never ever done any.
Until what we do,
Yes, sir.
in case the swelling does not resolve,
Yes, sir.
for about 6 to 8 weeks,
Yes, sir.
we do a sonography.
Yes, sir.
And in the sonography, if there are many septae and material,
Yes, sir.
which is seen, then it is a resolving hematoma,
Hematoma.
which has to be evacuated. It will never settle down.
Never settle.
So that is what our policy
Hematoma
is.
will never.
So to define whether it is hematoma or it is seroma,
Yes,
it is
sir.
better to do a sonography,
Sonography.
and define it properly and then act accordingly.
Yes, sir. There is a small trick here. So the oblique needle, because of oblique, I just pierce it, then turn the needle like this, then support the mesh and like pierce
Beautiful.
it. Yes, sir.
Beautiful.
Very nice.
Very nice. Sendhil has got lot of
Lot of tricks to learn.
under his arm.
Wonderful.
Sir.
Lot of tricks under his arm.
So now you can see I'm putting two instruments here and going to deflate. So just put two instruments here and make sure that it is coming and hugging it nicely. Okay, thank you very much. Thank you. Thank
Wonderful,
you.
wonderful presentation, Dr. Sendhil. You
Thank
can
you, sir.
hear the big round of applause for you.
Thank you.
Wonderful. Lot of take-home messages and tricks learned from your surgery.
Thank you, sir. Thank you.
Very good
much.
dissection.
Thank you very
Thank
much.
you.
I'm putting my hand on the scrotum and opening this
To deflate the
valves to deflate the carbon dioxide which is there in the scrotum also. So put your hand gently. Don't push too much. The mesh will move. So just put your hand and gently press it, so that the carbon dioxide which is staying in the scrotum also will come away while deflating the carbon dioxide. Thank you very much.
Thank you.
Thank you. Thank you. Thank you.
We generally put in a mop there.
Yes, sir.
I put in a mop and then give a external pressure onto that scrotum. That's
Then
what
we'll
helps.
put a few gauze pieces on fold. We'll keep one over the other, and we'll put a nice
External
plaster.
pressure.
External pressure.
Yeah.
Thank you, sir.
Thank you so much.